I'm going to actually introduce our next speaker, Dr. Frank Lin, who in many ways just needs no introduction. I've had the privilege of knowing Frank for several years now. So Frank did his undergraduate actually right here in Providence, and before he moved to Baltimore, where he's been ever since. He did medical school and residency in Johns Hopkins, and he's now on the faculty at Johns Hopkins. He did a fellowship as well with Dr. Thomas Lindner overseas. His work has really become, remarkably well-known, and with good reason, because he is looking at large-scale databases that have to do with hearing loss and aging. And we have the privilege of hearing him today speak to us on hearing loss and healthy aging. Dr. Lin.
Good morning, everyone, and thank you for your attention through all these talks today. So it is with great pleasure that I'm here today to present to many of you who are really the target of all my research, actually. So the focus of my today is really going to be sort of zooming out and looking at the broader epidemiologic or population-based perspectives of what hearing loss really means and why it's important in many ways. So if we look at just a basic epidemiology slide, how common is hearing loss, using an audiometric definition of hearing loss, how common is it in the United States? And what you see, the prevalence, or how common is, it literally doubles with every single age decade across a lifespan. So by the time you look at people who are above 70, 2/3, nearly 2 out of 3 of every single adult over 70 in the United States has hearing loss. So you guys are not alone, believe me, right? At the same time, if we look at one of the most basic building blocks of hearing loss treatment, namely hearing aid use, right? And we look at how common hearing aids are used, what you see is that among older adults in the United States, that averages about 15%. And a lot of people, when they hear this number, they're like, well, it's just because in the United States, hearing aids aren't covered by insurance. And that's sort of true, but let's say if you go to, let's say, across the Atlantic to United Kingdom, where hearing aids are fully covered by National Health Service there and nationalized health insurance, their rates of hearing aid use are basically exactly the same. So it's not just an issue of money, right? And I think what it really gets to is this, is I think right now, at least with our current state of knowledge, hearing loss in older adults, there are some essential, basic, fundamental questions which essentially remain unanswered. What are the consequences of hearing loss in older adults? Why is it important, right? We know why it's important, but you look at the broader literature, there's no consensus on this at all. Secondly, how do we treat it effectively in the community? We know there's a gold standard way of treating now, but clearly it's not reaching 85% of the people out there. And finally, the last question, what's even the impact of treating hearing loss? Does it matter, in fact, if you treat hearing loss? And I think because these questions are unanswered, there's a fundamental paradox in our approach toward hearing loss now. So if I showed you this audiogram, which basically shows a mild, bilateral sensorineural hearing loss, and I told you this is John Smith, he's a 12-year-old child, I can guarantee you universally, educators, patients, physicians, even health insurance companies, right, will say this hearing loss has to be treated. It's going to impact how well that child can interact with his friends, how well he can listen to a teacher, how well he can be engaged, right? And yet all of a sudden, if this is John Smith, 67-year-old man, I can almost guarantee you the universal response you'll get is, you have a hearing loss, maybe you should think about treating it. Right? Yet the functional consequences, the functional impact of that hearing loss is exactly the same, yet there's a strict dichotomy and a paradox in how we think about hearing loss in older adults versus young children. So a lot of times, the first thing that I've done a lot of my research is really address this first question. Is hearing loss even important in older adults? What are the consequences? And in particular, I'll tell you, even though, like many of you, I'm very interested in hearing loss, the way I approach my research is fundamentally different. I don't start from hearing loss. My main concern is more as a gerontologist, where I start with healthy aging. That's what I care about from my research point of view. And what do I mean by healthy aging? I think it's one of those things you know when you see it. So this is Gladys Burrell. She was 92 years old when she finished the Honolulu Marathon, the oldest ever female finisher of a marathon, right? So clearly a picture of healthy aging. In contrast, an older man in a wheelchair in a nursing home, clearly not a picture of healthy aging. Another picture, so a grandmother interacting with her granddaughter on a daily basis, clearly a picture of healthy aging, versus finally an older woman, probably with early dementia, alone in a nursing home, clearly not a picture of healthy aging. So when we think about healthy aging, there are many different components of it, right? There's cognitive vitality, avoiding dementia, et cetera, right? So the real question that I asked through a lot of my research is hearing loss related? Is hearing loss causally or mechanistically associated with these incredibly important outcomes of healthy aging, right? So to begin thinking about why would hearing loss, or how could hearing loss even be possibly associated with these important downstream outcomes, right? So I think intuitively a lot of people want to say, well, of course hearing loss is related to aging and cognitive physical functioning, mainly because there's some type of common aging process. Namely, as you get older, you're more likely to have hearing loss, and as you get older, you're more likely to have cognitive and physical functional declines. And if this is all that links the two, just some general aging process, it's actually not very interesting to me as a public health scientist, because it implies that if I treat hearing loss and I treat it well, I'm going to have no impact on these important downstream outcomes. So the real question then is whether or not there's a mechanistic pathway through which hearing loss could be causally associated with these bad outcomes, cognitive and physical functional declines. So begin thinking about how this could be so. This actually is going to touch back very briefly on what Dr. May described to you before. If we look at the general physiology of how we perceive and understand sound, in the top left is much like what Dr. May showed you before, a speech spectrogram, how speech sound, a complex sound, looks like if it's graphically representative. And you can see that sound's composed of different frequencies. Each frequency has a different intensity, and it all progresses in real time. And what the role of your ear's job, your peripheral auditory system, your cochlea, as Dr. Lim was describing, the job of your cochlea is to take that sound in and to encode it into a neural signal that then goes to your brain for decoding or processing, right? So fundamentally for the engineers in the audience, it's a process of encoding the sound and decoding of the sound, right? And what we know now when you have presbycusis or age-related hearing loss and damage to your cochlea over time is that results in increased hearing thresholds. You can't hear soft sounds. But more importantly, this is what Dr. May was going over before, is you have poor frequency resolution. In other words, you can no longer encode this incredibly complex sound with very good fidelity. So by the time the neural signal goes to your brain, then you get a very garbled message, right? So in other words, and we've all been in a situation before, maybe you're in a situation right now in this room, especially if you don't have a telecoil on, right? Is that what you're hearing from me sounds garbled, and your brain basically has to work harder to process it. And this has been described many times in this past as this process of effortful listening. They basically work harder to listen, right? So the question then is hearing loss possibly associated with these downstream outcomes through the idea of cognitive load? And what I mean by this is that does your brain actually have to rededicate resources to help with hearing and processing of sound, and does this then come at the expense of other cognitive systems, right? And I'll tell you, this isn't a new idea. So for those of you who know him, Danny Kahneman is a Nobel-winning psychologist and economist from Princeton, and over 40 years ago now, he formulated the idea of cognitive resource capacity, which I think is a very intuitive idea. And the idea there is that for any given one of us at any given point, we have an available pool of cognitive resources to do thinking and memory, right? And what we know now with aging, as you age, all of us as we age, is that you have age-related declines in the amount of resources that are available for thinking and memory. So the question then is, if you also have a peripheral, you have bread and butter age-related hearing loss, does this impose a load then on the number of resources that are available for other systems, right? So this is one idea. I'll tell you the second idea through which hearing loss could be directly mechanistically associated with these bad outcomes is incredibly intuitive probably for all of us in the room, is through the idea of social isolation. That if you have a hearing loss, you just can't be as socially engaged as compared to someone who has normal hearing, saying you don't treat it, right? And I'll tell you this idea of social engagement, if we believe this is true, that hearing loss can lead to social loneliness and disengagement, that is something fundamentally profound. If you look at the geriatric and the gerontological literature, one of the most important determinants of morbidity, heart attacks, dementia, hospitalizations in older adults is loneliness, right? And these actually is not through some type of hokey pathway. There are direct neurobiological pathways through which loneliness leads to these outcomes. And I briefly summarized it here. I mean, people have hypothesized and looked at people are more socially isolated. They're less likely to hear the medical treatments. Also, psychological pathways, self-esteem, self-efficacy. But actually, probably the most important one is the last one, which is a direct biological response. People who are socially isolated and lonely actually have increased activation of stress pathways in their bodies, right? And basically that activates cortisol and these inflammatory cascades. And what we see that as social isolation, and many studies now, is actually associated with upregulation of pro-inflammatory genes that increase inflammation. And these in turn cause direct neurobiological effects on brain aging, right? So two very, very viable pathways through which hearing loss can be mechanistically associated with these incredibly important downstream outcomes. So I'm going to show you some research now, and a little bit, maybe a little abstract, so I'm trying to go over as clearly as I can. And the first thing I've done in a lot of my research now is look at the relationship between hearing loss and specifically cognition and dementia. And the reason for this is because, from a public health standpoint, going forward for the next 50 years throughout the world, there is probably no more pressing public health problem than dementia. So we look at the prevalence of dementia being sort of the end stage result of multiple insults to the brain and to the cognitive systems of the brain. What you see is the prevalence, how common dementia is going to be. It's going to double every single 20 years over the next 40 years, mainly because of the aging of the population, right? So to put this in context, what this means then, 2050, in the entire United States, every single American, of all Americans, 1 in 30 of every single American will have dementia. Every single American. If you look at older adults, people above the age of 70 years old, 1 in 8 will have dementia, right? The numbers are staggering, right? And right now, there is not one single curative or preventive therapy for dementia, nothing at all, right? So let's look at dementia. So when we think about cognition or thinking and memory abilities, there are many, many different ways of measuring thinking and memory abilities. You can look at memory. You can look at measures of executive function. Executive function gets at how well you can process two different streams of information simultaneously and pick between the one that you want. This will become clear in the next few slides. The thing I want to make clear, though, is that when we test cognition, thinking and memory abilities, these tests are not verbal tests. These tests are not dependent on hearing ability. So if someone is not doing well on this, it's not because they can't hear, right? These are all nonverbal tests. I'll show you what these look like. So classic tests of executive function, you're presented with a very large sheet of paper with letters and numbers on it. And basically all you have to do is go from 1 to A, 2, B, 3, C. You either alternate back and forth between the two different streams of information, right? It's a classic test of executive function. You basically score how quickly you can do it, right? So clearly a nonverbal test. Something called Stroop Mix is a classic neuropsychological test of executive function. And what you have to do here is you need to name the ink color. So you would go red, green, blue, green, red. that actually wasn't intentional. But it's actually a hard test because what this does is for all of us in the room, it exploits the fact that for all of us, reading is a completely overlearned and automatic task, whereas naming ink color is much harder. So you have the named ink color, you're basically timed to how fast you can do this. So again, clearly a nonverbal test. Finally, something called the digit symbol substitution test, another classic test of executive function. You're presented with a row of numbers. Each number has a certain code. And you basically need to fill in the blanks as quickly as you can, right? So focus on working memory, short-term memory, and things like this. So again, classically, a nonverbal test of executive function. So what I'm going to do is zoom out a little bit now and show you some broad-based population data, epidemiologic data, looking at the relationship between hearing loss and these cognitive thinking skills, right? And in particular, I'll show you data from three different data sets. There's something called NHANES, which is basically this representative sample of the U.S. population. Something called the Baltimore Longitudinal Study of Aging, which is this longitudinal study at the National Institute on Aging that's been going on for over 50 years now. And finally, something called the Health ABC study, which is a study of about 3,000 older adults followed now for nearly 15 years, right? And I'll show you data for basically some from each of these. So we start with the simplest analysis. Let's look at how hearing loss is related to this cognitive skills. This is in the digit symbol score. In a population of older adults throughout the United States, about 600 adults, all in their 60s, right? And if you look at the raw data, this is what you get. On the x-axis, you have the severity of hearing loss. Again, higher numbers obviously mean more hearing loss on the audiogram. The y-axis, your digit symbol substitution score. And what you see in higher numbers are better on the DSS score. And what you see in general is that hearing loss increases. That appears that people's DSS, their digit symbol scores, decline. And if we apply some more sophisticated statistical modeling to this, where we can account and adjust for factors like age and sex and education, income, all these things that could potentially affect hearing loss and potentially affect cognition. We account for all of these in our analyses. What you get is this, is that if you look at the second column, for people with hearing loss, for every increasing 25 decibels of hearing loss, basically going from a normal to a mild hearing loss, that on average, that your scores on the digit symbol score decline by about 3.9 points. I mean, so what does that mean, right? And the way you can figure out what this means clinically is you can look at, well, what's a similar association between age and cognition? And that's the first column. If you look at for every increasing year of age, on average, people score about half a point lower. It makes sort of sense. With aging, it declines. So the last column is the one that really assesses the clinical impact per se. If you look at the change in age and years and its association with cognition, and the equivalent with that with 25 decibel hearing loss, it's nearly 7 years of aging. So a very, very clinically significant effect we're talking about. Now, this is just one study, right? People say, this one study is just, it's a sample of 600 older adults. I mean, what does that mean, right? Maybe it's just as a fluke in this one study. So let me show you some more data. So we look at the Baltimore Longitudinal Study of Age now, a completely independent data set. We look at about 350 older adults now, none of whom have dementia, none of whom had cognitive impairment. And we look at similar analysis, and now we're using two completely independent cognitive tests, the Stroop mix I showed you before and the trail-making bee. So three completely independent tests now. And we do the same type of analysis. What you get is this, is that the change in age and years again, equivalent to a 25 decibel hearing loss and its effect on cognition, is nearly 7 years of aging. So two completely independent data sets, three completely independent cognitive tests, and nearly the identical results, right? Now, if you're an epidemiologist in the audience, what you'll say now is, well, Frank, that's great, but this is just cross-sectional data. These are data sets where you've only measured every single person once. Show me data where you've been following patients now for a long time. So let me show you that. So this now is looking at a third independent data set. This is data from the Health ABC study, the Health Aging and Body Composition study. And this is 2,000 older adults, all older than 70, right? Followed now for nearly 15 years, but we're basically looking at just 6 years of data now, right? And all these 2,000 adults at baseline had no cognitive impairment, had no dementia, and now they all had their hearing measured at baseline. So what we're going to look at is their hearing loss at baseline and their rates of cognition, their changes in the digit symbol score over time. And this is what you get. On the x-axis is a study year. We began in year 5 per se, and we followed to year 11, so 6 years of follow-up. On the y-axis is someone's digit symbol substitution score. These are the average results across groups of people. And if you look at the dotted line, the people in the dotted line are people with normal hearing, and the solid line are people with hearing loss. And basically what you see is at baseline, people with hearing loss had poor scores on the DSS at baseline. And then basically over the 6-year time span, what you see is that on average, that people with hearing loss had about a 32, nearly a third faster rate of decline on this very simple test of cognition over 6 years, right? So lastly then, so what about, you started this talk with dementia. Dementia is the thing we care about. Dementia is the end stage result of multiple different cognitive insults to the brain. Is hearing loss related to your risk of dementia, right? So let's turn to another study now. So look at 640 adults in the Baltimore Longitudinal Study of Aging, all follow now for over 10 years. At the beginning, all of them had no dementia, no cognitive impairment, all of them had their hearing measured, right? And we look at the raw data, this is what we get. So this is called a Kaplan-Meier plot. On the x-axis is the time from baseline, time from when we started following them. The y-axis is basically the people who remain dementia-free. So obviously at time 0 baseline, no one had dementia. And if you look over the next ensuing 10 years, that the risk of dementia was clearly related to the severity of your hearing loss. And if we do, again, these more sophisticated statistical analyses where we can account for things like age and race and education, diabetes, smoking, hypertension, we see the results are basically the same, that compared to people with normal hearing, people with mild hearing loss had about a twofold, or called a hazard ratio, about a twofold increased risk of dementia. Those with a moderate and severe hearing loss had about a 3- and 5-fold risk of increased dementia over time. So this is the question that I always get next from any hearing loss audience, and in particular, this is my 89-year-old grandmother, who's very spry. And when I told her some of my research and what I was doing, she looks at me, she's like, and this is in Chinese, she says, "Are you telling me that I'm going to develop dementia?" Right? And the answer to that is a definitive no, and I think this will become clear when I give these examples, right? So right now, what we know from epidemiologic and broad-based clinical trials is that if you have high blood pressure, and probably nearly half in this room probably have high blood pressure, right? You are, in a population-based perspective, at increased risk of having heart attacks and dementia. Does that mean if you have hypertension, you're going to develop dementia? Absolutely not. From a population-based perspective, though, a population of people with hypertension versus people who don't, though, are at increased risk. So what do we do now? From a public health perspective now, widely, we promote lifestyle changes, low-salt diets. We promote medications for hypertension, right? And because of that now, there's good clinical evidence that makes an impact, right? Likewise, people with sedentary lifestyles, if you don't regularly exercise for 30 minutes, 5 times per week, you are at increased risk of dementia and having strokes. Does that mean if you don't exercise at all, you're going to develop dementia and strokes? No. But from a population-based perspective, that's the risk we're seeing. But because of that, and there's good clinical evidence that show this now, is that if you regularly exercise, as someone mentioned in the audience before, you have healthier rates of brain aging, and you're at reduced risk for these things. Not so much dementia, we don't know that for sure yet because those studies are hard to do, but for strokes, absolutely, right? Likewise now, from a body of research now, we know that the hearing loss is associated with accelerated cognitive decline and dementia. So the intervention there, comprehensive hearing rehabilitation, of which a hearing and other instruments are just one step, right? But the funny thing about hearing loss versus other two, though, is that there is absolutely no public health recognition that hearing loss may be important in this regard, right? And the rates of hearing aids, the most basic step of hearing loss treatment, is used in less than 15%, even in fully funded healthcare systems. Right? And I'll tell you, one big issue going forward is this, is that the question of whether treating hearing loss and treating it well could delay cognitive decline or dementia remains completely unknown. So in the history of science, in the history of our field, there's only been one ever randomized controlled trial study of hearing aids ever done that has looked at outcomes beyond just quality of life. That's it. It was done 40 years ago by Cindy Mulro's group at University of Texas and 200 VA veterans. That's all that's been ever done showing the effects of hearing loss treatment, right? So I'll tell you at Hopkins right now, there are a couple studies we're doing. We call them the SMART studies, which is an acronym for Studying Multiple Outcomes After Oral Rehabilitative Treatment. And SMART 1, which is an ongoing study right now we're doing, is we're looking at older adults who are getting a hearing aid or cochlear implant at Hopkins. And we're looking at the effect of the hearing aid or cochlear on people's thinking and memory abilities as well as their social functioning. But the big study we're gearing up to do right now, which we're in the planning stage right now with many, many different people, is a definitive, what we call multi-sites or different centers throughout the United States, a randomized controlled trial study, right? So basically taking a bunch of older adults, all of whom have hearing loss, who have not received any hearing loss treatment. Half them get the gold standard hearing rehabilitative therapies, other half just get watchful waiting per se. And we look at rates of cognitive decline dementia over time. Because this would be the study, if it does indeed show an effect, that would demonstrate that treating hearing loss and treating it well can have a huge impact on public health outcomes, right? So I'll finish up with this slide, and it's basically what I started with. And I think there's some fundamental unanswered questions about hearing loss in older adults. Why is it important? What are the consequences? I think we're beginning to get this little now, right? The second question, I think this is what Brenda Patat really commented on nicely yesterday, is how should hearing loss be effectively treated in the community? Our system right now, it works for some and probably works for many of you in this room, but it does not work for the vast majority, I would say 85% of older adults. Something needs to be done differently, right? And finally, what is the impact of these actual treatments, right? That's something we'll hopefully get to in the next few years. But what I'll say, though, is I think because these questions remain unanswered, there are a lot of consequences and observations we can make about our current status of hearing healthcare in the United States, right? Rates of hearing aid use are less than 15%. This has not changed in 3 decades, despite the improvement of technology. And it is not only because of funding, right? If you go to the United Kingdom, where hearings are fully covered by insurance, the rates are absolutely no different. So that's not the only issue, right? Second thing, hearing loss, it is not understood to be an important public health issue at all. Right? It's amazing. If you go to the Centers for Disease Control, the CDC website, which is the main public repository of public health information, there is not a single mention, not a single link about hearing loss in older adults. Nothing. There's hearing loss in kids, critically important, we know that right now. Not even a single mention about hearing loss in older adults. Likewise, if you look at, you put your money where your mouth is, right? If you look at funding levels now for vision research versus hearing research at the NIH, right? Our budget for hearing research is about $400 million. For vision research, a completely analogous sensory modality, which is less common than hearing loss, their budget is more than 50% more than ours. This has not changed in 2 decades, right? Thirdly, lack of insurance coverage. We know this already, right? No insurance coverage at all, right? Prove it to an insurance company that hearing loss makes a difference, right? Last thing, and this is something I feel very, very strongly about, and I've probably talked to many in this room about, is that our current model for hearing healthcare, we completely place an overemphasis on the idea of fitting a hearing aid rather than comprehensive hearing rehabilitation. The end goal for an audiologist, for anyone who works with you with hearing loss, it's not to fit a hearing aid. That's not the end goal. The end goal is to make sure you communicate, right? And to make sure you can communicate effectively. And if that's the end goal, it's not all about a hearing aid. Hearing aids form one step in the process, but there are also loop systems, which David Myers spoke so eloquently about yesterday. There's aural rehabilitative classes. There are other type of assistive listening devices. It's a whole pantheon in many ways of different technologies and rehabilitation that needs to take place if the end goal is communication, not just fitting a hearing aid, right? And lastly, I'll mention that second to last, I guess. I mean, hearing aids, the problem with hearing aids right now, as all of you guys know, they're $4,000 or $5,000 device for a pair of hearing aids. And the problem with the industry right now, and this is what I've talked to you several about this in the room about this, is that they remain low volume, high margin devices, right? Low volume, high margin, right? So the evolution that needs to take place, hopefully over the next 20, 30 years, is that they need to be progressed to a high volume, low margin device, right? And just to give you, probably many of you know this already, so Adrian Davis is sort of the father of hearing healthcare, I would say, in the United Kingdom. He's one that sort of implemented universal newborn hearing screen in the UK. And when he negotiates on the behalf of the National Health Service for purchasing high quality bilateral digital hearing aids, they basically buy them in bulks of almost $500,000 at a time. When they negotiate that price, right, their cost for a pair of high quality digital hearing aids is about $200 US, right? So they don't cost more to make than that, right? And yet the markup is almost 5,000%, right? It's fundamentally a high margin, low volume device, and there are a lot of inefficiencies in the delivery chain right now which need to be addressed, right? And the last thing I'll mention, this one, which I feel strongly about, is the idea a hearing aid is just one step. And I think Dave Myers sort of spoke this so eloquently. Hearing aids are probably just personal amplifiers. But what really matters going forward is how well that device in your ear can connect to other devices, to the hearing loops, to your phone, to other public address systems, right? And right now, there are no common standards at all, short of a hearing loop system, right, with electromagnetic technology, which is old technology, but it works. There are no common standards at all across these different devices. So if you buy a Phonak hearing aid, you have to use a Phonak streamer. You have to use a Phonak streamer with your TV. You can't switch another device, right? So you're locked in. There's no interconnectivity, and that's what's critically needed going forward. So I'll finish up there, and I'll say that I have an absolutely wonderful set of collaborators at Hopkins and throughout the National Institute of Aging, which has made this research possible, and I'm very, very indebted to all of them. Thank you very much.